Welcome, everyone, and thank you for joining us for How Inclusivity Promotes Equitable Healthcare Outcomes for Black, Indigenous, and People of Color. I'm Kayla Quebec-Alton, Curriculum and Programming Manager at the Diversity Movement. Today's webinar is moderated by our CEO, Donald Thompson, Certified Diversity Executive, Forbes Next 1000 honoree, and a speaker, investor, and advisor to many. This includes serving on the Vidant Medical Center Board of Trustees. He will be joined by our three extremely esteemed panelists. Julie Kennedy Ehlert, a doctor of nursing practice and registered nurse, and the Chief Experience Officer at Vidant Health. Julie has over 3 decades of expertise and wisdom gathered from a life of working in healthcare. She started her career as a nurse aide at the age of 14, and since then has served in a variety of clinical, operation, consultative, and strategic roles across the healthcare continuum. In her current role, Julie drives experience and culture at Vidant Health, including patient experience and team member experience. Dr. Nora Triola, Chief Clinical Officer at Bayata Home Healthcare. Nora has more than 25 years of experience as a nurse executive, including Chief Nursing Officer positions with Broward General Medical Center, Imperial Point Medical Center, and Methodist Hospital, and roles as a System CNO with Catholic Health East and Trinity Health. She holds a PhD in nursing from the University of Miami in Coral Gables, Florida, where she also received her master's in nursing. She is a Wharton Fellow and serves as a Magnet team leader and appraiser for the American Nurses Credentialing Center and is certified by the American Nursing Association in Nursing Executive Administration. And last but certainly not least, we have David Cade, CEO of the American Health Law Association. David is a tireless advocate for diversity and inclusion in his field and for healthcare delivery systems, and has advocated for greater focus around the issue during his time in both the public and private sectors. Throughout his career, he has created a collaborative environment where public and private sector parties can come together to discuss the most challenging legal and policy issues impacting the healthcare system, including financing, reimbursement, compliance, quality and patient-centered care, fraud and abuse, corporate governance, emergency preparedness, and numerous coverage of eligibility policy issues. Thank you to our panelists for being here today. As has become more evident than ever due to COVID-19, healthcare inequities based on race, gender, sexuality, culture, religion, and other dimensions of diversity plague the United States and the world. Inequities are apparent in maternal health, care quality, nutrition, vaccine access, and so much more. So, what can and are we doing about it? This is the driving question we hope to answer today. Before we get started, we have a quick 2-question poll for you all that I will launch now. So I've just launched the first question in the poll, if you wouldn't mind responding. I see some answers coming in, and I will give everyone about 30 more seconds to respond. Thank you all for participating. I will share the results in just a few more seconds. All right, so I'll close this poll and share the results. So we had 59% say yes and 41% say no. And I'll go ahead and launch the second related question. Please take a minute to respond. Thank you for participating. I see those answers coming in. Give everyone about 20 more seconds here. All right, and I'll close that out and share the results. So quite a few different answers, but the majority saying not being taken seriously or listened to. I really appreciate everyone sharing that. Remember to share your participation in this webinar by tagging the diversity movement on LinkedIn, Twitter, Instagram, and Facebook, and use the hashtag TDM webinars. Now let's jump into our program. Donald, the mic is yours.
Kayla, thank you so much for setting things up and setting the table for us today to have this very, very powerful discussion. And I'm so excited to be able to, not so much for me today, share, but really listen and learn and just help guide the conversation. We're going to have a robust question and answer availability towards the end of the session. So feel free to use that function within the webinar programming. And Kayla and I will manage and monitor those questions as we go. One of the things that I want to set as a reminder is I'll ask a couple of leading questions, but for our panelists, if you want to extend on a thought of one of your colleagues, please feel that freedom and space to do it, even if I've directed the question to someone else. So let's jump in. And Dr. Euler, I'm going to start with you. I want each of you to talk a little bit about your organization and its DEI journey. And so when we talk about diversity, equity, inclusion, and we talk about the healthcare landscape, there's still a very specific set of functions and factors that are dealing with Eastern North Carolina in the case of Vidant, or a large home health care, or from a legal perspective. So I'd like each of you to take some space and talk about your organization and its DEI journey.
Thank you, Donald. So Vidant Health is a rural academic health system in Eastern North Carolina. So we serve about 1.4 million people that are largely in rural healthcare settings, which also can equate to low trust communities or communities that are not served or don't have the ability to be served in other venues. Our largest academic medical center is about 1,000 beds in a town of 90,000, and a little bit of a weird anomaly, right? And then we have our smallest hospital being a 6-bed hospital in a very rural community. We've been really committed to leaving resources in the community. So we do have cancer centers in rural areas, and we have about 100 clinics, many of them in very rural settings. So when we really started looking at our demographics, started looking at our social determinants of health, which, rival those of Mexico. Our infant mortality rate is in Eastern North Carolina is worse than Mexico's. And so we had to do a lot of really hard thinking about how do we approach this work. And this did happen before the pandemic. And we did something interesting is we decided that most of our team members were patients, right? Because in a town of 90,000 with a 1,000-bed academic medical center, pretty much everybody works at Vidant or has a family member who works at Vidant. So part of our DEI journey was to start on the inside and to take a look, not so much at metrics yet, super important to have the metrics of our patients, but team member metrics, looking at, the structures that, the racist structures that we had in hiring practices. How about payer equity? How about team member belonging? So we spent a lot of time assessing inside, knowing that ultimately, if we had a workforce that looked like our communities, that we would ultimately be able to advance diversity, equity, and inclusion for our patients. And so that was the beginning of our journey. And I think it served us well when we got to the pandemic. But I would also say that sometimes that juxtaposition of, we're going to work on team member equity and inclusion to get to patient equity and inclusion can be lost on people. They're like, what are you doing about, equitable mammograms? And it's like, well, we're working real hard on inside us, knowing that the people will then drive to the equity for our communities. Donald, you're on mute. That was brilliant.
One of the things that is really powerful is when you think about Vidant, for example, and Nora, I'll come to you in just a moment. It's one of the largest hospital systems in the country. And one of the things when you think about Eastern North Carolina and you think small ball, right, Vidant is doing medical care at scale, right, that rivals some of the largest healthcare systems, right, in the country and the world, and should be very, very proud of that. Nora, I want to pass the baton to you and talk a little bit about Bayata and your DEI journey.
Sure. As serving as the Chief Clinical Officer at Bayata has been a wonderful opportunity. Spent, as you sort of introduced me, spent most of my time in acute, and this has been a wonderful transition to be in home health care. And at Bayata, we have over 360 offices located in 23 states and 6 countries, and a long history of serving vulnerable populations. We serve adults and children in all sort of centers of healthcare, whether that's home health or hospice, or some of our shift and hourly kind of personal care services for individuals that are very complex and trach invented and spinal cord injuries, those kind of individuals, intellectually disabled individuals, keeping them from needing to be in group homes. And so since the company's founded in 1975, the vision that Mark Bayata had was to really serve a vulnerable population and see them for the individuals that they truly were and have them live their best life. And to do that, one client at a time in various locations across the country. And sort of what we've learned along the way is that there is more need than we can almost ever deliver on. And we're constantly opening new offices and adding to service lines so that we can continue to really help individuals fulfill what for them is their dream outcome, to live their life at home in the comforts of their surroundings with their family, and really be able to bring services and support to them rather than them go to some of the the facilities that sort of we've established over time. I think our diversity journey has started at our board of trustees, really embracing that curiosity. I think it's been hundreds of hours because, just as Julie said, we started with that internal examination of ourselves and trying to understand from our colleagues what was working well, what needed to be really thoughtfully reconstructed. You can imagine that just by the fact that there are almost 28,000 of us as Bayata employees, many of those are clinical individuals, many nurses, physical therapists, predominantly female, but how that employee population mirrors the clients we serve has always been an important point in services. Clients welcome us into their homes, and they need to feel comfortable with who we're sending. And sometimes there are those crucial conversations about race and diversity and individuals that want different individuals to come to their homes. And so it's teaching, listening, educating, but we've really, I think, embraced the journey and recognized that there's so much more we want to do and so much more that we need to raise a level of awareness. The whole unconscious nature of people wanting to do the right thing, but inadvertently maybe setting up some practices that don't represent all populations the same way, that aren't as inclusive as they could and should be. So it's really that curiosity that the board started, our leadership team embraces, and we're learning, changing policies along the way. And I couldn't be more excited about the time, because I believe now is the time to see some of these old standing policies change.
Nora, that's really, really powerful. One of the things that I would just echo that you described is the board of trustees creating that reflective moment, and then the leadership team leaning into it. And so anytime you're leading and growing organizations at scale, right, people model the behaviors of their leadership and the focus and intentionality of their leadership. And so to hear you describe that kind of support is really, really powerful. David, I'll turn the microphone over to you for a few moments.
Right. Thank you, Donald. I've been the CEO of the American Health Law Association for the past 6 years. And prior to that, I was a member of the board. And as a member of the board, not being on staff, I had a shorter stint in private practice in health law. But most of my career has been in the government, at the Department of Health and Human Services, not only as a staff lawyer, as a senior manager and the deputy general counsel and acting general counsel for that large organization, but also spending time in the Medicaid Bureau, working with family and children's health programs, and along the way, supporting Indian health for our indigenous population and working with HRSA for their FQHCs throughout the country. So there's, in my own DNA, the DEI journey started well before I came here. And I think I brought that desire and whatever knowledge base you gather along the way to the association. And while not a clinician the way Nora and Julie are, to understand that intersection at the front line and the linkage to the patients and the payers and the policymakers and that general governance structure. So when I look at AHLA and its journey, and I think like both of the other panelists, the journey does continue. And Nora's right, we're looking for where we are and where we can go during this new window of interest and opportunity. It also for us started with the board and looking at how can we address not only our own DEI journey as an association that is at the forefront of health law education, recognizing that excellence in health care, which is what we're all after, starts with excellence in health law, those who are practitioners in health law, which sits at that juncture of governance in any organization. And so our board in its wisdom took a moment and said, we have to look inward at our own governance structure and start that journey. We then have to look outward in how we can capture lessons learned from what others are doing and be, again, at the center of it all to identify better and best practices for governance in health systems throughout the country and around the world. And so our journey was working in those camps. And so in the inward looking, we looked at our own structure and what are we doing as an association? What does governance look like? Who are our leaders? How do we develop and nurture the talent pipeline for leaders in the association and leaders in the industry, and making sure that we have our finger on the pulse for diversity, equity, and inclusion? Similarly, how do we look at the opportunities we create to educate and making sure that the education opportunities, those who are invited in to write, to speak, to share their lessons learned, also represent the industry, the mosaic of the individuals who are in practice. And another element of that is how do we also make sure that we are multidisciplined? It's not just lawyers talking to lawyers, it's health law practitioners, all those involved in health law and healthcare coming together in that multidisciplinary approach. That, I must say, was one element that really allowed us to reinvigorate, if you will, diversity, equity, and inclusion. And as a lawyer, I guess I can say this to the masses, and I think Nora and Julie might agree. We can oftentimes come to the table as the crabby lawyer, the snobs in the room, the elitist in the room. Maybe they teach that to us in law school, I don't know. But you run the risk of not being inclusive, even at a professional level, and diminish the value that the other professionals bring to the table. I've seen it. Sad to say, I was probably part of it. And so when we talk about diversity, equity, inclusion, and we particularly talk about the disadvantaged populations, for me now in this seat, where I am focusing most of my attention, it deals with the governance and the leadership of the organizations, transcending down into the practical operational tools that folks are deploying in order to be more inclusive in patient care, in patient access, in patient delivery. And so for me, that journey started many years ago, recognizing when we, as I think is about half of your population indicated in the survey, that you were excluded, you were not part of the process, and therefore not part of the solution when we're looking at the diversity, equity, and inclusion journey. And so again, for us, we are now sitting at that center of providing guidance to the practitioner community that are providing guidance in the field at the clinical level on how best to structure your programs to be as inclusive and open as possible.
Oh, that's perfect. David, thank you so much for that. And Nora and Julie, let me dig into some questions, and I'll really extend on what David was talking about as we look at the governance and these scalable organizations, but then we drill down right into that linkage, right, to excellent healthcare and that patient experience. So the question for the panel, and Nora, I'll start with you, and then we'll go to Julie and to David on this one. What can people do? What should they do to better advocate, right, for their own excellent experience when working with healthcare professionals and situations? When we look at the survey, there were 59% of the people that said that they didn't feel listened to in instances where they had those experiences. So I'm very interested on some lessons that we that are receiving healthcare from institutions can do to make sure that we do receive that best outcome possible.
So it's a great question, and I think that it starts with that relationship that as a client or a patient that you have with your healthcare provider, and really being able to share those concerns, to be able to be open about those concerns. We regularly look at feedback from our clients. This isn't 20 years ago where it was sort of my way, and we didn't really necessarily solicit the feedback from our patients as much as we could and should. And the expert here is Julie on that, but the whole experience of making individuals feel safe, and from a nursing background, being the trusted profession for all the years that we've been trusted, means that we're open to ask those questions and allow clients to express their concerns, to really understand how they access care, what quality care looks like and feels like. The assumption that everything is quality at 100% is not realistic, and most of our clients need some education around what quality care looks like, and that they have the access to the same and comparable levels of care. So making sure our offices are in areas of underserved populations where we are able to match the employee population with the clients that we serve in certain geographies. All those build an infrastructure that hopefully creates for the clients the ability to express themselves more openly. It is a constant journey. There is, and particularly when we talk about, folks that are more senior in their years, they defer to healthcare expertise and don't necessarily think that they should challenge or ask questions. Some of our younger population is much more internet savvy and has read everything on social media and comes with their list of questions. And so that's a whole nother challenge in itself. But, I think that dialogue is really important, because it's where they can express, some of their concerns and some of their vulnerabilities.
Oh, that's powerful. Julie?
So much there, right? Thank you, Nora. So what I always think about is, are you willing to let the people that you provide healthcare to run your healthcare? And so there's so many lessons to be had if you listen. And you have to listen with empathy, and you have to put in new listening channels, because the listening channels we have are for a very segmented part of the population. I've had so many lessons when I just took the time to listen. When we first got here, we started meeting with community leaders, and they said, why don't we meet in our communities? Do you not come to our communities? Do you not like our communities? And we're like, ooh, we should have meetings in the communities we're trying to serve. Why do they have to come to Vidant? And so we started meeting in the communities. Then we started talking to people, and they're like, we don't really want health fairs. Could you get us some jobs? And we're like, wow, we've been wasting some money on health fairs when people really want jobs. All right, so we have to switch how we're thinking about this. And so creating different listening channels, and I had this best lesson from one of our Hispanic Latino, he's a very strong leader in our Hispanic Latino communities. And he said, what do you do when patients complain? The Spanish community, the Spanish speaking community complains. I'm like, we don't get many. He said, that's because no one speaks Spanish that answers your complaint line. And I was like,
wow.
So that was my next thing, right? He taught me. So I think opening new listening channels, and then understanding that these communities, and we call them low trust communities for a reason, because we don't think it's as judgmental, but we're reminding ourselves that they don't trust us. And so what are we doing to gain their trust so they'll even tell us? I think we spend a lot of time just getting new channels and then getting people to trust us. And that means being present, listening, listening forever, right? Until somebody finally says, okay, you might be all right. And then making sure that what they think is important is what you're doing. We were doing ED surveying. We were doing patient experience surveys. I'm a chief experience officer, so that's kind of what I do. And we were doing ED patient experience surveys. And after about a month, I'm like, if the patients leave the emergency room and they can't get their meds, they can't get a ride, they can't get a primary care provider, why am I surveying them? And so we took all that money and we made a call line. So after people left our emergency rooms, we called them and said, do you have money to get your medications? Do you need a ride? Do you have a primary care provider? That was much better use of that resources. But we don't know that. And I loved what David said, you know, inclusive as open as possible. You just have to listen. And I don't think that we've listened in healthcare. We've listened to a group of people like this, and we've surveyed a group of people like this. And I just think we have to have new listening channels, and we have to really challenge ourselves with empathy and decide that we're going to let the community run healthcare innovations versus us thinking that we know what they want.
Wow, that is really powerful. I want to not add to, I want to amplify a couple of things that you said. In terms of opening new listening channels, stage one, and a lot of people are doing that, right? But what you described is the commitment to act on what you're learning. And that, to me, starts to really create the difference in impact, right? It's one thing to create the avenue for someone, a leader in the Latinx community, to share that there wasn't good representation, right, on the call line. But then for you to go and change it is where success lies, right? To change up the surveys to action-oriented questions. Do you have a ride? Do you have a provider? That's where success lives, because people, when they see those points of progress, that's really the only way you build trust with people that don't trust you, is an action you can point to of how you're behaving different. Because the marketing, the rhetoric, the town halls even are so negatively portrayed, right? Because if I come into a meeting, right, and I'm prepared to dislike you, it is really difficult for you to change that narrative. But if I come to a meeting and I hear the things you've done to support people that look like me, now all of a sudden, even that negative narrative is now challenged with those measurable actions. And so that is really, really, really great. David, I'll turn to you. Same genre of question in terms of what can we do on the ground? What can we encourage people to do to where they're a participant in that better healthcare outcome?
Yeah, I definitely support what you've heard. What can we do? And I think Nora started, Julie picked it up. It's education, and to amplify, I guess, a couple of the other themes that have impacted this. You used the first one to use the word trust, and it picked up on the theme I think that Julie was talking about. They don't trust, we don't trust, because people didn't care. It's very hard to trust individuals in a system that doesn't trust back or care or listen. Nor use the word empathy. If I know as a patient, you're reluctant to see me, you're reluctant to touch me, you don't care whether I'm there or not, I don't matter, trust isn't that high. You add in those complications that come with age and education, it makes it even harder. And you know, how do we navigate the system and to see change? Yeah, I think education is at the core of that. But we know education has its own discriminatory theme throughout. And so when we talk about education, that's kind of easy, yet are we attending to it? And Nora said the younger generation, which has access to the internet more regularly and is coming to the table with greater power than some others in our population, they oftentimes are now threatening the clinical community, because now someone's coming in with some knowledge that's threatening what I, in my sort of patient clinical hierarchy, because you know, historically the patient's always at the bottom of the hierarchy. The clinical hierarchy goes all the way up, and those above know best, and they tell you how you're feeling. They're not always listening. What you're hearing best for Julie and Nora is things are different and are getting better. But when we talk about historically, and what brings us to this table is people didn't listen, people didn't care. The patient was at the bottom of the list, and those who are disenfranchised trail far below. And so education brings us to the table. It begins to level the playing field. You become your own advocate, but then you have to have a voice. You have to be able to crack that wall of clinical hierarchy to say, this is what I read, this is what I know, this is what I hear. And it's so important that education is coming there, and the power of the internet and those who are having the access are able to gather that information, because it's not generally available. And so, you know, as much as we talk about healthcare, you know, it forces us to, again, look at, and I'll introduce the other term for the day, those social determinants of health, which also impact what happens in that clinical engagement. And education is at one of those roots, and empowerment is at one of those roots, for folks to feel empowered enough to say, I don't like this, I don't understand this, help me, or in the room, I don't have access to the meds, instead of waiting for the phone call, you know, to ask earlier on. You know, we're hearing the best practices, and it's about patient empowerment, patient education, and a system like what you've heard being described that cares enough to ask. And as you amplified, Donald, not just ask the question. It's not a survey for the sake of a survey. I'm asking the question with the intent to listen and learn and react. And then we're putting the patient first.
No, that is powerful. I'm taking a bunch of notes myself, because one of the things we're talking about is healthcare outcomes and different things, but we're also talking about, right, leaders that serve, right, and healthcare professionals at every level, right, are leaders, right, and in order to serve someone, you have to understand them, and in order to understand them, you got to really care enough, right, to ask those questions. Let me take us a little.
Donald, can I just add something? Because Julie brought up something that I think is so important, and it reminds me of a story. But so we've talked, you know, in this part of the segment, we've talked a lot about the individual client and their relationship and voice with a clinician. But I think when I think about that, and I think where Julie was saying more and listen in different venues and continue to expand that, is where we see the use of, you know, patient and family advisory councils, where we see a sort of, and I remember the story when I worked in Catholic healthcare, where some of our sisters would pull up a chair and say, this is the patient, and this is our patient, and the patient is at the boardroom table. And we would start with a story of, Mr. Jones and bring that client into the room, then they would, sometimes have the actual patient come in and tell their story. And I just think that there are multiple ways that we get above just the one-on-one interaction and really can change then policies and processes and our whole structure to be, as David said, not with the client at the bottom of the pyramid, but flipping it over so that it really does seek to understand what are the client's needs and how do we then shape the healthcare system around them. And it's much more client informed. So it's just, I think we see that as a best practice in some organizations, some real cool stuff being done to bring that voice of the consumer into the healthcare arena today at a much more sophisticated level, with councils and seats on boards and presence in those kind of venues.
No, that's powerful.
Point.
No, Nora, thank you so much for jumping in. Before I move on, Julie or David, anything else you'd like to add on those points? Nora, that was great. Thank you.
I just want to tell a cautionary tale that you can empower patients and families, but if an organization has so much structural racism and so much biases that those patients just are devalued, humiliated, because they come and they say, this is my condition, this is my worry, and people go, that's not that important. Did you really not have a ride? What's going on? And so the work at hand to dismantle the structures that we've put in place that stop even empowered patients from being heard is really, I think, our work, because we saw this in the pandemic. We saw that we could not reach out to low trust communities. We couldn't even get empowered communities to respond because our organizations were not willing or didn't even have the infrastructure to respond in a way that wasn't equitably tone deaf.
Right, and that's sort of the crux. Well, not the crux. It to me is a perfect example. The pandemic hits, and you realize, oh, whoa, we can't reach them. Well, you weren't reaching them before the pandemic, so it's not a surprise that you're not reaching them in a pandemic. So for years and decades and generations, they were over there, I was over here. You didn't reach them. There's an isolation. Members of the board aren't from the community, and you all know there are many boards where the leadership doesn't come from that community. They are not even serviced by the facility when they're on the board. So there's another disconnect and an isolation from truly understanding the community we serve or to care about. And so that level of neglect, it just fosters and fosters and festers. Here comes the pandemic. It's not a surprise. The people in public health, the folks who had the real boots on the ground, knew this because they've been living with it and trying to address healthcare with Band-Aids and baling wire for generations. And now the problem hits, and we're focusing on, the problem didn't hit, the awareness for many are now seeing it. The question is, what are we going to do about it? What are we going to do that Nora and Julie are doing nationwide to reinvest and to make that change so that, as you said, Julie, people are speaking, and they're speaking to folks who are willing to listen and change. Because if you don't value the voice, you're going to ignore it.
Yep.
No, that is powerful. I want to change the specific question that I'm going to go to next, but it is a similar thread, right? We now have vaccines that are available for people to significantly reduce their risk of COVID-19, right? And we have a very distinct division between people that are accepting of this data and science and trusting to now go and get the shots in the arm. And then we've got a very significant group of folks, whether it is socioeconomic, whether it is political, that are very resistant to now taking this vaccine. And so I'm very interested in your perspectives of how we've talked about trust, we've talked about some of those gaps, but this is like real time. So I'm interested in what you all are doing within your organizations real time and learning about how to better communicate the value to all of us that more people trust the system and take these vaccines. And I'll start David with you on this one, and then we'll pass to Julie and to Nora.
Again, another outstanding question, Donald, and it comes, you know, with as you say, with a focus on the vaccine, but the focus on the vaccine is just a little microcosm of the larger issue of discriminatory practices in healthcare delivery. Healthcare disparities have been known since we started collecting data, and the question is, well, what have we done about it? And you know, all the things that lead to the question, as I said a moment ago, are part and parcel of a system that has been broken and not inclusive enough to address the issue. And so while we understand the problem, the question is, okay, so what are we doing about the problem? How are we addressing it in not just a crisis way to deal with the vaccine, but in a way that has legs to address the problems long term, and not just for the next pandemic, but to address some of the problems that deal with what caused us to be here and to see the disparity that exists. So one level is addressing the privilege issue. You know, when you look at some of the statistics, you realize that the communities that have been most ravaged by COVID have less access to the vaccine, and the take-up rate is a little lower. It is part of the larger problem of the health disparity and where people are with transportation and internet and all those things that we talked about. So how do we deal with that? So we have to deal with the transportation issue. You have to deal with the trust issue, not just, you know, take this shot, but to create that connection of trust in the community, which is larger than the vaccine. And so we are beginning to build a process that we are here to care for you and the community. And yes, the vaccine is one of the reasons we have to get out there, but I have to get out to the community, to where you are, and not ask you to drive 3 hours across town and sit in a car that you may not have to wait in line for a vaccine. So we have infrastructure issues, we have education issues, the whole transportation issue, all those things need to be addressed that lend to connecting with the community to build the trust so that I'm getting my mammogram, you're dealing with my diabetes, you're dealing with my clinical challenges, and I am now in a care community where I think we are easier able to then introduce the vaccine. It is part of the public health infrastructure that we have let crumble over the generations. So the key for me is reinvesting into the healthcare system where patients are, and not just waiting for patients to find their way into the clinical system, but to truly have a focus on our patients are here, our clinical engagements may be more isolated, but when we look at it from a public health point of view, we have to have a plan to get our healthcare out into the system and the community. So the advantages of telehealth have moved the needle very far. We have to continue to invest in that. Understanding who's providing the care. It's not in that clinical hierarchy. The clinical hierarchy historically has said, all this is for the doctors and this is for the nurses. We've started even pre-pandemic to stratify that a little bit, move things around so that the patients have greater access to what they need when they need it. Investing in the infrastructure is one way to address that, but you have to sustain this. This is not just a one and done, it's something we can do in 6 months in an effort to address some of the lack of trust, lack of access that is causing the community to not have trust in taking the vaccine. And the last thing I'll say on that is, you use the word the politics. You know, leadership is key. And when leaders are not clear on the information that's necessary for people to make decisions, we have chaos in the community. That leads to a lot of distrust at all levels. And that's impacting what's going on now with individuals being willing to take the vaccine. We are soon approaching a way or a period of time where access, at least availability, we won't call it access, availability is not a problem. The question is, we have yet to solve the access problem and then to begin the process of overcoming the truth and trust problem so that folks understand, yes, it is safe for me to do this. And yes, it is appropriate for me to do this. So we have a lot of stuff ahead of us to work on, short-term and long-term.
Yeah.
So thank you, David. So we did so many things, and Donald, I've been lucky enough to have Donald on our board, is we came into this very eyes open, knowing that we had to address trust issues and we had to get communities vaccinated and keep them safe. And we are very proud that we vaccinated African Americans and Hispanic Latinos at 2 or 3 times higher than they did in the state. But we did that through relationships and trust. So we gave iPads out to our church leaders. We had them come and tour our vaccine centers. We let people self-schedule. When you ask an IT person in a healthcare system, you gave an iPad where people could self-schedule into your self-scheduling model. We're like, yes, we did. We did it. We did tours of our vaccine center to make sure it was safe. We did WebExes with doctors who were very involved in our rural communities. We did Facebook Live from our vaccine center. And I really want to say that we worked with the communities to say, what do you think would make people feel like this is something they could trust? And so they helped us, and we made sure the experiences were great too. No lines, anybody could get in. We made lots of concessions for people. Sundays were a time when we would do a Hispanic Latino day where everybody in our huge vaccine clinic, we could vaccinate about 3,000 people a day. We're bilingual. We had all of our signs were bilingual. We made sure it was very friendly. We made sure that people had food. And then when we started moving into the communities, to your point, David, when we started moving into the communities to give them on site, we did it with a lunch, a barbecue, something in the community. We would take our vaccinators to the homeless shelter. And so I don't think that there was ever one solution. The solutions come from the communities you serve. And so if people called us and said, can you vaccinate everyone at the Purdue chicken factory? And we'd be like, do you want to come on site? Do you want to bring them? Do you want us to bring food? Do we want us to sign people up for primary care providers? Again, I'm going to go back to what I said before. If you believe that healthcare is run not by the people who you serve, then you have to rethink. Because as long as we listen to our community leaders, especially in our low trust communities, and said, how do you think we should do this? And they told us. And so we worked with them. The other thing that I think was really thoughtful is that we did a lot of social media, because what we found out is even in Eastern North Carolina, social media is very powerful. And even though people might not be on, I don't know, some forms of social media, they're on Facebook. And so we did a lot of Facebook Live. We did a lot of our community leaders that said, hey, look, I'm getting my shot. A lot of our doctors talking to our communities. We just did so much to create a feeling of, hey, let's do this together. And then we, again, listened and listened and listened. And now we're at this place where the people who aren't getting the vaccine are more the politicized group than the low trust communities. And that is because we spent a lot of time just saying, hey, what makes sense? How does this make sense for you? And being with them. This, and I have to say, David, when you were talking, I was feeling very sassy about when you said, you know, now this isn't anything new. And it's like, well, we wanted to reach out to low trust communities during the pandemic because we wanted to stop the spread. And that was something we wanted to do before it's things they need. And so really, I mean, just calling that out, that, you know, you didn't really need to talk to your low trust communities until, oh, you need to tell them about, you know, masking and all of that. And then the other thing that I would say is I was very proud of our leadership team, because many of us are nurses and doctors, and our executives gave shots. So our CEO went down to our EVS team, and our VP, who is a nurse, we gave shots to them ourselves. And the VP of our clinic said, you come in for team members, for patients, I'm here with you, I'm giving shots. And it just became something much more joyful than I think most places. But that was because we listened to our communities and we listened to people. We listened to our church groups. We listened.
That is, I appreciate both the structural part of the conversation and then just that on the grounds action orientation. And there's so many things that we can do with innovation and trying new things that don't necessarily cost a tremendous amount of money, but they do have a high cost in will.
Yeah.
And intentionality, right? There's an effort tax, right? And so you really have to get out there and demonstrate, right, that you want to be a part of that change, and then people will respond to that. Nora, I want to give you some space as well.
Well, thanks. And, you know, Julie, I think your examples are just magnificent. For us, we were not able to take receipt of vaccines. So our model, you can imagine, is very distributed. We're in homes. We've got clients in homes. We have caregivers in homes. And how are we going to sort of make this happen so that we can educate, increase access and availability, and you know, support individuals getting their vaccines. So we did a lot around dividing up the geography and creating vaccine scouts, if you will, individuals that would look for the afternoon when XYZ pharmacy had extra shots and get that out to populations so that they could fill those precious slots that came available. We did a lot in the beginning with creating linkages between and amongst pharmacy partners, health systems, and our clients and their caregivers, family caregivers. And we then sort of experimented with clinics and have done quite a few clinics in different geographies, always giving preference to our home health aides and those individuals that are not sitting in an office, you know, able to hit refresh and get that available spot. We made sure that, you know, there were hours. So we were open very early in the morning and stayed late at night for those different geographies so that the home health aides finishing their shift could come. We've done some paid time and some, you know, I think the other thing is really just being really transparent in the conversations with our employees and their family caregivers and the clients. You know, we do YouTubes every week and talk, and the vaccine is a topic that I probably spend, I don't know, 3 of the 4 Fridays talking about with the thousands of caregivers that open the YouTube little app and listen to me every week. You know, but there's just a lot of conversation about it. You know, I was planning that we were not going to look like the statistics. We were not going to have 65% of the vaccines that we sort of helped organize be given only to, you know, white Americans, and, you know, that our Hispanic population would be mirroring the 12%. I mean, it's so, I think, to me, important to identify that this virus is preferentially attacking vulnerable populations, you know, our Hispanics and our Black Americans, and yet we haven't as a society prioritized making sure that those individuals get the vaccine first. In fact, we've had that vaccine now available for 6 months, and I would say that vaccine equity is you know, just not reflective of where we should be as a country. And, you know, Bayata has worked hard to do that, being a partner, though, not what Julie's done with 3,000 vaccines a day. We only wish we could do that because we've still got, you know, homebound clients. Now that vaccine is becoming more available, pharmacy partners are willing to give it to us to take it to the homebound so that we can vaccinate them and they don't have to find a way to get, you know, to a center. We've also done a lot of work with scheduling appointments for our family caregivers and the clients to make sure that they can get there and accompanying them to the centers. But this is a bothersome subject for me because I don't think we've really changed the trajectory enough to make sure that those that are most vulnerable are getting the vaccine.
Yeah.
Yeah, Don,
Please go ahead, David. Yeah.
I just wanted to ask, I mean, what is so present for me in this, and that is, you know, I think the pandemic and the reaction in many ways highlights healthcare as a privilege in this country. And I think the distribution of the vaccine is another, illustration that it's a privilege in this country. And while we reacted, I think in a magnificent way of getting the vaccine developed and beginning the process to distribute it, it overlaid that system where for many it's a privilege. And so the privileged among us were able to get to the front of the line, even though the impact, as Nora was just describing, of the disease, it didn't initially hit the most privileged among us. So that imbalance is part of the problem. And I think you ended, Nora, sort of on a more sad note. And it's like, well, but yeah, there were lessons learned. And I'm hopeful that since we're not out from under the cloud yet, that we are now doing the things that are more in line with healthcare as a right. And the president spoke about this when he was giving his address to Congress. It's a right, not a privilege. And if that's true, then we are obligated to pay more attention to those inequities and doing what is necessary to reach all in the community with a true understanding of those who are most impacted should be at the front of the line. And then using the tools to create that connection, and not just the convenient tools that made it easy for the distribution, which was more like, as we sort of classically say, well, banker's hours. So in the old days, if you wanted to get your banking done, banker's hours. You couldn't bank 24 hours a day. You couldn't bank late at night. Things changed. And then there were clinical hours, doctor's hours, the same kind of thing. Not in tune with shift work, not in tune with what is going on in the community. So we're learning. And as you described, and both of you, about your distribution of the vaccine, you're meeting the needs of the community. That has to be sustained, and not just to sort of address the pandemic, but to prevent the next pandemic and to deal with some of the other disparate health outcomes. We have to sustain what we're doing now and keep it in the community and keep connected. And that's where I worry. I share you where I don't know if we're going to do it.
Yeah.
David, it's really interesting because this has been our discussion at Vidant Health since the pandemic. And I see Nora shaking her head, is can we take what we did with vaccines, because we learned so much,
Right.
and can we do that with health screenings? Can we do that with dealing with some of the social determinants of health? Because let's get real, we can just do basic medical model. That's not going to help my communities. That's
No.
they need jobs, they need food, they need education, they need so much from us. And what we learned in the pandemic has to be the way that we propel ourselves forward. And we have talked about this so much, that the never waste a crisis, that what we learned about reaching low trust communities before the pandemic, and also, let's be real, during the huge social unrest in our country, what we've learned is our way forward. And we've even went so far to say it is our brand, because we have, in the pandemic, we have rebranded ourselves because of how we listened and what we did. And we got to spend some time with Donald Thompson's team working with low trust communities, and we learned so much, and we will not let that go, because that is our future. And we believe that's our brand now, that we have blown up the traditional models and said, okay, they didn't work before, we didn't really understand, now we know what works, and this is going to be our way going forward for our communities. But I love that you say that, because that is has been our discussion for the last 8 months at every executive level. How do we maintain the trust that we have gained by going out into our communities and listening, providing education, giving masks, helping people? How do we keep going to advance the health of all of our communities?
That is really powerful. And I am I'm struck by a couple of things that I'll share, right? And there's certainly, to Nora's point and some others, there's so much work to be done, right? Like that is real. I want to flip it and put that optimistic hat that I have to wear to keep my focus in different things as we work through these things. Is there's also a lot that is learned, and there's so many more people that are digging in that you all are representative of. That gives me hope. And people that have the ability, right, to impact others because they are in leadership positions, that their mindset is now that client first mindset. Like you've all used some different words and terminology, but in essence, right, it's looking at healthcare through the lens of the client and letting that order your steps and behaviors. And I think if we can capitalize on that kind of momentum, right, in the things that we write about, in the journals that we talk about in terms of what healthcare should look like next level, we can continue to make that progress. And so it leads me to my next question, and I'm going to think about the future a little bit, right? There's a lot of things that we have to work on, but what have we learned that has us optimistic? What are we seeing that has us optimistic that we can do more and do faster? And Nora, I'm going to start with you on that question.
Oh, great question. You know, and I am optimistic. I do believe that there are conversations going on now, and there's a recognition. You know, for years, I think that we all experienced inequitable care. As a new graduate, I saw it. I didn't understand it. I believed that nurses had, you know, this sort of ability to treat anyone and everyone, and they do, but there still are controls and access points and issues of, you know, of differences between and amongst how ethnic communities get cared for. And I think that a lot of people may not have had top of mind realization in the differences in the real literature around cancer and diabetes and different outcomes for cardiovascular disease amongst different ethnic populations. And I think that COVID has sort of created a level playing field. These individuals did not do any more risky behavior. They didn't do anything, but this virus attacked Latinos and Black Americans, and you would, if you're in healthcare, you would have to be somewhat out of touch if you didn't recognize that that was a main issue here. And I think that creates the condition for everyone to say, well, we're going to go forward in a positive way, recognizing, as opposed to, I'm not sure the literature on cancer is as strong as it should be, and maybe there aren't that many differences between how ethnic populations are dealt with, and you know, the outcomes are different in Black Americans. I mean, you know, you can argue that literature, and I don't think you can argue anything with COVID right now. I think that we saw what we saw, and now I had hoped that vaccines would be a model, and it sounds like Julie's team, you know, has done an amazing job and should be. You know, we're going to find those best practices, but this is the stage for, I believe, changing how we deliver healthcare, and that we do meet the needs of our different populations where they are, what they need, and that it affects not only access, but it affects outcomes, quality, level of care, and really it becomes what, as David said, you know, our president is talking about, you know, a right for all individuals to receive high quality, efficient, equitable care.
Yeah, I'll turn over to you, David, in just a second. I want to make a comment, right? Because we always have to work on eggshells a little bit when we talk about the political and different things like that. And I totally respect that. And that's one of the beauties I love being an entrepreneur, right? Is I'm hard to fire. Not impossible to fire, but hard to, right? And I think that we cannot gloss over the fact that the macro messaging in our media and in our politics is creating a different set of narratives with people and how they view any type of system. And it's not making the work easier, right? Because we're now not only talking about what Biden is doing and what Bayata is doing and what American Health is doing to be advocates for change, we also actually have to be communication specialists to balance misinformation. And so one of the things in my next question as we dig in, we talked about the optimism for a minute, but there's so much information now. So how do we help people understand what are the right sources of information around healthcare that can be trusted? Where do I go for that data when I want to do my research, right? As a client or as a patient advocate board or any of the things we talked about, how do we manage and battle and overcome that sea of misinformation, right? That is really becoming, I think, a cog for those that are trying to do the best possible intent, right, with growing healthcare and providers. And I'll let you all just weigh into that. David, I'll give you some space, and then we'll get to Julie and Nora.
So this is a tough nut to crack, and I do, after almost 30 years in the government, working for the Republicans and the Democrats, and believing in the core of the mission of HHS, I understand the pendulum as it swings, and I try to walk a narrow line at times, and so I'm guilty in that space. Yet I also know we will never change what we tolerate. And as long as we tolerate discrimination, we tolerate bias, and we tolerate that it's okay to have variations in health outcomes, we will never change it. So as long as we tolerate it, so using the pandemic as another door opener to address the larger systemic issues, the systemic racist issues that have impacted healthcare, yeah, I have optimism. I believe, and I embrace the words that the president used, because he talked about transportation and education and broadband and eradicating lead in our pipes so that we can stop polluting our children, in 2021 and 2022. So we have now lifted up some of the basic elements that impact healthcare. So that gives me optimism. I also have optimism because I look where I am today, and I look at my journey, my own personal health journey, and those in my family and friends, and I look backwards. And I see where this country was. While we still have major problems and a lot of isolation and ignored communities, and communities that are, are still being, infected by toxic waste dumps that are nearby, and diesel fuel and diesel exhaust, those things still exist. But where we were as a country 50 years ago, 60 years ago, 70, far worse. So the historical view gives me that optimism. The challenge you ask in your question about, as I would summarize it, well, what are the facts? And while we have a lot of fact discussion and ping pongs back and forth, to me, one of the things that did ring true is at the clinical level, the science level, while it was spun by pundits throughout the past year and a half, the hardcore science, and as the community of scientists were evolving and learning what was going on and sharing that information, there was truth. So you're right, sometimes we have to get a little bit away from the punditry that is spinning all this stuff for a variety of reasons, and look at what the scientists are saying. What's the core? What are the facts? And there, I think we can find some common ground and use that as a launch pad to help educate the community. There is a challenge, though, because when people have tried to do that, they sometimes get smacked down through the punditry. That has been truly part of the problem that's existed for not just the past year and a half, but throughout our history. What are the facts? We have arrived at a point where we understand that people are people. Black women don't have a higher tolerance of pain than any other person. So let's give them the meds that I gave to the white woman who's in labor. We have slowly started to overcome those bias and the discrimination that has existed forever. But it's by addressing the real science. And so, as I said, you pose a question as a tough nut to crack, because when our science is polluted, and it has been, then the misinformation is out there and it's harder to overcome. And when you have that inconsistency and then you spin it with punditry, another hard nut to crack. to try to educate people and help them understand what the real facts are. So
Yeah.
believing in science, trusting the science, those are root issues that'll help deal with the issue.
No, that is super powerful. I'm going to do a quick housekeeping, and then Julie, I'm going to go to you, and then Nora. So as we wind down our time together, because I could talk with you all and listen to you all for hours, right? But one of the things for our audience is please submit any questions you'd like us to address in the Q&A. Make sure that we do that. And then what I'm going to do is Julie, as you answer the question on information, I also want you to think about any closing thoughts of something I might not have asked that is important to this conversation. And Nora, for you as well. And then David, I'll give you some space at the end. So Julie, I'll turn it over to you.
And I want to thank Nora. We've done work, but there's so much more work to do that we will not rest 1 minute. We are still a very learning organization. And when you think about all the communication, I'm going to talk kind of crazy about this, but I think that people listen to people who they know love them. And love and empathy are the keys that we know unlock our social determinants of health. I can show you data that says that African-American women aren't getting their mammograms, but if you don't love them and care about them and you don't have empathy for that, I'm not sure that people try hard to solve things. And so when we started this journey at Vidant to really think about a culture where love and empathy were at the forefront of our work. Love your community. I mean, you'll take care of your community if you love them. And what we found when we went into the pandemic was that there were so many sad things that happened. I mean, the pandemic, it crippled many people. Our team members suffered, our communities suffered, people lost their lives. And I watched our board and our executive team just lean into that. You know, just lean in. These aren't numbers. These are people's grandmothers. These are children people love. And so I think that the whole communication thing, yes, there's so many communication. What are you going to communicate? I think that the only way people are going to listen to you, no matter what you choose to communicate, is if they know that you love them.
That is,
that's that. I mean, that's that.
That is awesome. Nora, I'm going to go to you, and then we're going to take some questions from the audience, and there are a bunch. So I'm going to try to prioritize
It just reminds me of what we live by every day, the Bayata way, you know, and how we really do focus on compassion, excellence, and reliability, and you know that we love our clients, and you know, we want them to live their best lives at home. And you know, I think that as I say, the journey can be long, but we've got you know, a lot of good things to accomplish, and I'm very excited that we're where we are. I think for us to sort of put it into practical steps, you know, when we say how are we going to embrace diversity and really be a different organization, it starts with recognizing and respecting that individual client and knowing them, their plan of care that's individualized, that involves the family, you know, that really lets that client show us what they need and want in their healthcare. You know, that we give time for clinicians to be able to know their clients and know them well, and that we're curious as learners, and we're not going to get it always right. We're going to make our mistakes, but we're going to reflect, and we're going to continuously trying to improve our journey, recognizing both, you know, how we can listen more and change some of the structures that are inherently a problem in our culture.
No, I appreciate that very much. Here's one of the audience questions, and this is a big one, right? Why is the maternal mortality rate, excuse me, for Black women 3 to 4 times higher than white women? Is racial bias a cause for this?
I think it is. I think racial bias is a cause. And in the optimism I think that we all shared, we're still dealing with apathy and indifference, rooted in racial bias. I won't say that that is the only cause, but when you have access problems and you have racial bias, stereotyping, and apathy and indifference, it causes individuals who have historically been treated less than to be marginalized. And the health treatment is different, and therefore the health outcomes are different.
Julie?
We could do a whole other day on about that metric, which should break everyone's heart. It should break your heart. But I think when you come right down to it, it is because of structural racism, it's because of bias, and we should just say it is. All of the reasons that lead to that are all tempered by the fact that we obviously don't care enough to correct those variables.
Mm-hmm. Mm-hmm.
Well said. Well said. And if there's an equalizer, it may be COVID-19. If we all can commit, I'm so optimistic about the nurses' future of nursing now in 2020 to 2030 is all about disparities in healthcare and eliminating them. And if you think about, we could get 3 million plus nurses on board with this agenda. We could get, health and hospital systems on board with these kind of agendas. We can move forward, because Julie's right. This is an embarrassing statistic for a country that is the wealthiest country in the world. To have infant mortality rates where they are is unacceptable in my mind's eye.
Yeah, and it's solvable. All the things that we've talked about that impact this, if care and attention was provided to it, to and including prenatal care, which is also meted out in a disparate way, we can address this.
Totally.
That's powerful. As one of the questions from the audience, and this is really what we're leaning into also, what changes in our education of healthcare providers should be done such that we are producing that next generation, right, of healthcare leaders and practitioners, right, to really be addressing these issues from another systemic structure, which is how we're training, right, providers. What are some thoughts there?
I just want to give a shout out to Brody School of Medicine, who we have the honor to work with. They actively recruit diverse local students. And most of the providers who graduate stay here with us and take care of their families. We have a community hospital in Duplin County, and there are 4 brothers there that their parents live in that community. Their siblings live there, and they practice there. And I think when we started talking about, healthcare and what's different about healthcare now is it's very fragmented and it's become transactional. And so I think for us we need all the education that we need for providers, but I think that you should deserve to have a provider that understands your situation, that looks like you, that talks like you, and that you feel like you can trust. And so I think, again, want to shout out to Brody. Their class this year, their class during this pandemic is one of the most diverse we've ever had. And many of those physicians will stay here with us in Eastern North Carolina. So we can't continue to just foster the structural racism that only allows certain demographics to go on to practice the art of medicine.
Yeah, I would add 2 points on top of that, and I'm doing a big amen to you, Julie, on that. If your leadership is not diverse, shame on you. If the folks in the boardroom are not diverse, shame on you. If your hiring panels are not diverse and you're not interviewing a diverse slate of candidates, shame on you. Those are things that add a lot to the change that we're talking about. I would also add one other point to that, and that is we also have to realize when the clinicians or the students come in to be educated in whatever the clinical profession is, we also have to realize that we're doing a lot of rewiring, because nobody's born a racist. And yet the bias that exists is all learned throughout their maturation and growth. So by the time they come into the clinical experience, there's a lot of rewiring that has to go on. You have to learn that you have biases. And then you have to figure out a way to have that in the forefront of your mind so you can overcome it when you encounter folks who aren't like you in the clinical experience. That's a lot of work. Not everybody's doing the work. And so I think the folks here are doing the work. The folks on the call, I hope, are doing the work. But we have to realize there's a lot of work that we have to do, because the people who come to you, who you're going to employ to address these issues, many of them have to be rewired.
Well, I want to just do a challenge to people listening. If you have any access to your patient experience data, and we use human caring questions as well, if you're not running it by race and gender, then you can't see what your care is like for certain demographics. And so we report that out to the board. We started, and we will set goals on the gap, because you can see it if you want to see it and say, okay, these people, this group of people says the care is great and loving and kind. This group, not so much. What are you doing about that? And if you wash it all together, you can't see it. So that's my challenge, is if you're not running your patient experience data by race and gender, then that's what you need to go home and do right now.
That is all. I mean, and Nora, I'm going to give each of you all some space for like a 1-minute parting comment, and then we're going to wind it down and be careful with everyone's time. But I want to say to the audience is there are several questions we have weaved in through the conversation, but there are a few that we didn't get to, but we will. By signing up for this web event, right, we have access to your email address and different things of that nature. So we'll work with our panelists and maybe have them just do a short iPhone video or via email. And there's maybe 6 or 7 that we didn't get to either in the conversation or et cetera, that we'll make sure get answered, right, as we release this video for broadcast. So I want to say that, number one. David, I'll start with you. Nora, I'll go to you, and then Julie to finish up. If you would just take 1 minute on a parting thought that you'd like to leave us with, and then I have just 1 or 2 closing comments, and we'll call it a day.
Yeah, I appreciate the opportunity, Donald and TDM, for giving me the space to join with this awesome panel to kind of share what we know and what we dream about in changing the healthcare system. You know, my parting thought is don't give up, and find your voice and keep your voice. I mean, we're here because I think for many and for far too long, we and others have been silent, or we've been talking to each other and not addressing the larger problems. And so as I said, with everyone, I think we all share the optimism, because we are a better community than we were many, many years ago. We also come together and realize we can and must be better in our future. So we have to keep addressing these issues. And it's hard at times. It's frustrating a lot of times. But if we don't continue to address it, it'll never get addressed. And so I think what you're hearing for today, and in this window of the pandemic, we have a window to continue to move the needle and hopefully can sustain it, so that we have a true healthcare delivery system, a public health system that is strong enough to handle a next pandemic, but more importantly, that we have a system in place that is addressing the needs of all patients, so that we are a healthier society. And I do believe we can get there. We have to continue to work and foster the community of care. What Nora said, love and empathy. There's a lot of work that we have to continue to do to make sure everybody comes to the table in that spirit. And so it can be done. We just have to work together.
That's awesome. Nora?
Been a great panel discussion, and we could spend, you know, probably many more hours talking about a whole host of topics and bias and all sorts of interesting, you know, things that I think come here today because we believe that we have a responsibility to do better. And, you know, if I had a couple of things to say, I'd say start now, start today. Recognize that we have a great case study in COVID-19 to use as a platform for that conversation. To look at if you don't have diversity in your boardroom, or you're not looking at a slate of applicants for positions that is reflective of, bring that up, talk about it. The more we can create implementation science and learn lessons and try new ways of doing things, the more successful I think we'll be. I don't think this is something that needs a huge strategic plan. It needs, as Julie started us, listening closely, activating our social justice responsibilities, and coming to the table to try new interventions to make a health system that does care for all Americans, and improves not only access but quality outcomes, so that we really are the country that we aspire to be.
That is awesome. Julie, 1 minute.
So good to be on this panel with all of you. It's great. And I thank you to everybody for joining. This work is a personal journey. And if you lead anything, healthcare, business, do your work, take your journey. Structural racism will not be dismantled without every single person having a personal journey to see it, to acknowledge it, to care about it, to have a desire to make it be something different. Structural racism was built by us, and it will only be dismantled by us. So if you lead anything, start your journey. Don't just start with your organization, but start with your own heart and start to really expose yourself to the things that are going to help you be able to lead DEI work into belonging for America, for all of us.
That is powerful. David, don't give up. His parting thought. Nora, start now. And Julie, love and empathy. And I learned so much from this process, just listening and be a part of it. I want to thank you all for giving your time and your intentionality in what you're doing every day when the lights aren't on, right? When people aren't seeing. Thank you all that have attended, right? How inclusivity promotes equitable healthcare and outcomes for BIPOC community. As a next step in your DEI journey, we invite you to download our assessment to see where you stand and your organizational readiness to implement effective DEI strategies. Kayla will drop that link in the chat right now. Also, one of the things that we pride ourselves at the diversity movement is having very powerful, effective, action-oriented, free content, because we want our mission to extend to all. So mark your calendar, the diversity movement's next free webinar, Developing a Diverse Talent Pipeline, on Thursday, May 20th, hosted by our VP of Business Strategy and Marketing, Sally Willingham. At the end of this webinar, we'll have a short 2-question survey. It helps us stay on task so that we're providing quality, actionable content, right, for those that are trusting us with their time, with their effort and energy. The final thing that I'll say to our panelists and to those that have attended is thank you. We have a lot of work to do in this space. We have a lot of responsibility in this space, but doing it together will create that optimism for the future and that accountability that we all need to do what's right for ourselves and our personal learning journey, but for those that we lead and serve. And so with that, thank you all and make it a great and blessed day. See you soon.